Welcome to the Census Mortality Database Workshop. This pre-workshop video is about publications and productivity using MDAC, TLMS, and their linked Medicare/Medicaid databases. My name is Sean Altacruz. I'm a project scientist with the National Heart, Lung, Blood Institute. My contact information is provided at the end of the presentation, and I'm happy to answer any questions if you send me an email. The real purpose of the workshop is to get us to the breakout sessions on day 2, where investigators can propose and modify and refine concepts using the MDAC, TLMS, and their CMS matches. Each one of these databases is at a pivotal stage. The MDAC is in its first 3-year funding cycle, and beginning in 2021, we're going to have to renew the project, and that means justifying the project based on publications and other metrics of productivity. The MDAC and TLMS linkages to Medicare and Medicaid data are available but haven't really been utilized. And we're very, very eager to see investigators use these extensive resources for a variety of health science research purposes. And the Tobacco Longitudinal Mortality Study is a brand new resource for looking at tobacco use and its effects on health and mortality. We are currently completing the match and intend to launch it shortly after the workshop in 2021. Our hope is that we can assemble a group of investigators who are ready and interested in utilizing this amazing, largest U.S. study of tobacco use and health for novel research. So I mentioned metrics for the renewal of MDAC, and there are several. Those include use by early-stage career investigators, the use of the resources for innovative research, the impact scores of publications based on MDAC original scientific research articles, and the number of publications coming from this resource. I'll give you some examples of publications that are already out there in this first 3-year funding cycle. So a very recent article by Mark Alfson and colleagues at NIH and Columbia University looks at the socio-demographic risk factors for high-risk firearms suicide in the United States. In addition, I worked with colleagues at the Census Bureau and NIH on a study of socioeconomic risk factors for fatal opioid overdoses in the United States. And Dr. Hawks recently published an analysis of mortality among Americans incarcerated in private versus public prisons. And currently, Mark Alfson and colleagues are submitting a paper on risk factors for deaths of despair in the United States, which is undergoing revision for resubmission. MDAC also lends itself to novel investigations of economic issues of our time, such as the rising inequality of life expectancy by socioeconomic status, an article published by Dr. Sanzenbacher and colleagues recently. And Peter Munich investigated with colleagues the effect of anti-poverty programs on mortality in the United States. In addition, Sarah Miller and Laura Weary recently published a very well-received MBR working paper on the effect of Medicare and Medicaid expansion on mortality in the United States. MDAC is also used for modeling purposes and for evaluating known demographic phenomena in the United States. So Elizabeth Arias, a project scientist for MDAC at the Centers for Disease Control and Prevention, National Center for Health Statistics, recently published one in a series of articles on the Hispanic paradox using MDAC data. And this particular article attempted to tease out the effect of race with Hispanic ethnicity in terms of the Hispanic paradox. It also looked at effects of nativity, being born within or outside the United States. And Jennifer Moss, who was a cancer prevention fellow at the National Cancer Institute at the time, worked with colleagues there and at the Census Bureau to look at the agreement between area and individual level socioeconomic data. And this is very important because area level data, typically gained from the American Community Survey, is often used as a proxy for individual level data. And to the extent that that assumption is correct or incorrect, it has implications for the findings using proxy data. I'd like to highlight some effort that several of my colleagues at the National Cancer Institute and Census Bureau are working on with me. We've used principal component analysis of county-level data on demographics, climate, and socioeconomic status to merge similar counties across the United States into national groups. This computer processing unit intensive effort identified 18 national groups. And then we used one of the larger groups and more diverse groups, the Cosmopolitan or big city diverse population, as a control for hazard analyses. When we did that, the Cosmopolitan group, which is in yellow in these maps, was at lower risk for all-cause death, or put another way, many areas had significantly higher risk, the exceptions being wealthy communities around large cities typically, the beach areas of the United States, and the middle of the United States, the midsection. When we looked at stroke-specific mortality, a few of the areas dropped out, and those included what we call Middle America and also the Mountain West. Chronic obstructive pulmonary disease mortality was similar to all-cause mortality, except that we also saw the beach areas at higher risk than the Cosmopolitan area. And cardiovascular disease followed a very different pattern. There were no areas with significantly elevated risk of cardiovascular disease mortality compared to our control group of the Cosmopolitan areas. However, the northern tier and wealthy areas had significantly lower risk of cardiovascular disease. So just going on with the theme of productivity, we have several groups that are working on very interesting topics. In particular, the Drexel University team has used zip code level data on various types of businesses to look at the effect of healthy food sources and walkability on cardiovascular disease mortality. In addition, a member of their team is looking at the effect of personal and neighborhood wealth on fatal injuries. And furthermore, they are looking at the effect of life expectancy by income in various U.S. metropolitan areas. Other investigators are looking at geospatial patterns of mortality related to local alcohol policies, to migration patterns within the United States, and to local labor markets. Once again, we want to see additional uses of the MDAC database and are very eager to receive new concepts. So, changing topic to the tobacco longitudinal mortality study, the TLMS is a linkage of all tobacco use survey data ever collected to the National Death Index. And it will provide the largest database on tobacco and health research issues in the United States ever. The primary sponsor is the Food and Drug Administration Center for Tobacco Products. And like MDAC, there will be a TLMS workshop breakout session on day 2 for investigators interested in the effects of tobacco on mortality. Although we don't have TLMS publications yet, we do have publications using the legacy NLMS linkage to the TUS. This is a smaller database than the one that will be available with TLMS, but it gives a sense of the possibilities. So briefly looking through them, Dr. Maki Inoue Chow and colleagues at NCI and Census and the FDA looked at the effect of low intensity and non-daily smoking on mortality in the United States. Dean Hosgood looked at lung cancer mortality among smokers and never smokers in the United States. And Carol Christensen at the FDA, working with colleagues at NIH and Census, looked at the mortality risks of U.S. cigarette, cigar, and pipe users. David Timberlake and colleagues used this linkage to look at the effects of smokeless tobacco use on mortality in the United States. Gary Fraser at Loma Linda University did a comparison of mortality in the Seventh-day Adventist cohort study and the U.S. population using NLMS restricted to non-smokers. He found higher rates of mortality in the U.S. population than the Adventist population, and that pattern was found in a stratified analysis restricted to African Americans. Carol Barrett at City of Hope Hospital looked at the association between psychosocial stressors and incident lung cancer in the NLMS TUS linkage. That particular analysis did a tremendous amount of imputation of missing data and that was a novel modeling effect. So once again, we're very interested in hearing your concepts. There's a process for doing this. If you go to census.gov, MDAC, and download the MDAC proposal form, you can use it to submit a concept sheet for either the MDAC or TLMS. It's about 2 pages in length. And then if you return it to the sponsor steering committee representative that's most closely aligned with your area of interest, you can expect a 2-week turnaround time. A list of sponsors and their contact information is also available at the MDAC website. Thank you.